So, good afternoon. I'm Kylie Rodriguez. I'm the benefits manager here at the consortium. And today we're hosting an Asthma 101 course that'll be presented by Jackie Czwojdak from Smith Allergy and Asthma Specialists of CNY. We appreciate her taking the time out of her busy day to present this information to our group. And just shameless plug here, we are kicking off our next wellness book club next month, focused on Dare to Lead by Brianna Brown. If you're interested in joining, please feel free to email the HC Wellness email and we'll ship you out a book to participate in the virtual book club. So without further ado, I'm going to turn it over to Jackie to lead us through the webinar.
Okay, well, thank you so much for letting me be a part of your consortium here. I've been in allergy, asthma, and immunology for about 7 years. So asthma, I've come to live and treat and be aggressive with my asthma patients. So I'm just going to kind of give the basics of like what asthma is, what can trigger asthma, and how we try to manage our patients. We will go over some things that can be potentially, emergent for asthma patients, and some common myths about asthma. And if you guys have any questions, you can certainly just shout them out. I have time at the end, hopefully, that I left for questions if you don't feel comfortable shouting them out. So, asthma essentially is a chronic, meaning a long, usually lifelong lung disease that affects your airways. So, typically, we're talking about the bronchi or the bronchioles. Obviously, these tubes carry the air in and out of your lungs. You can kind of think of asthma as an overreactive airway. So basically, normal things like smoke, cold air, dry air, those for whatever reason initiate an inflammatory response in asthmatics. It can affect people of all ages. We have patients as young as 6 months old. You can grow into and out of asthma. We have people who've never had asthma their entire life, and at 52 years old, all of a sudden they're having asthma symptoms. Asthma typically cannot be cured, but it can be controlled, and that at Smith Allergy is what we really focus on, is trying to control asthma so asthmatics can live their life without feeling the restriction of having asthma. Asthma is one of the most common chronic diseases that we manage in America. So, it is definitely something that we should take seriously. Now, this is just a quick basic anatomy review. We breathe obviously in through our nasal passages. That air goes through our trachea or our windpipe. That leads to the main stem bronchi, the two branches that carries air into the lungs, and then that goes to the bronchioles, the smaller branches, and that goes to the alveoli or the air sacs. Asthma typically is in the bronchi or the bronchioles. It doesn't usually affect the alveoli specifically, but if there is too much inflammation, obviously we can't get that oxygen exchange where we need to the alveoli. So it's important to treat the asthma so it doesn't come to that. When these airways are inflamed, we can't do what we need to do. So, what happens when we're having an asthma attack? Basically, the airways, there's a couple different things. A bronchospasm, which is basically a fancy word for a cough. What happens is the muscles around the airways, they kind of tighten, and that can provoke a cough. The inflammatory mediators are released when you're exposed. This creates inflammation in the lining of the airways. When we have inflammation, it usually goes into a hypersecretion mode, meaning it sends extra mucus or slime to the area. It's meant to be helpful, like it's trying to clear out whatever the obstruction is, but it really just kind of gets in the way. So that narrows our narrowing airway even further. And so now we're trying to breathe out of the tube that's about half the size as it should be. And that is a very terrifying experience for anybody who's ever had this. That narrow tube is basically what happens, is that wheezing sound that a lot of asthma addicts will experience. The bronchospasm, like I said, that's a fancy word for a cough. You're going to have some chest tightness. You're going to feel like, just doing basic things like walking from the bathroom to the living room is going to be, it's going to make you short of breath. It's going to be hard to catch your breath. Walking up a flight of stairs might be difficult. Um, the symptoms can definitely vary in patients. There are certain types of asthma, like exercise-induced asthma, where you don't have any symptoms unless you're exercising. We have some patients who have like an allergic asthma, which is they only have asthma symptoms seasonally. There is also called a cough variant asthma, where the only symptom they have is just a chronic cough. It could be dry and barky. It could sound like they've been a smoker their whole life with like a junky cough, but they're not smoking and they're not sure what that is. So the symptoms can definitely vary, but this on the inside is what's happening to the airways. Um, we focus on controlling asthma, basically trying to prevent asthma symptoms and asthma exacerbations. We know that, our goal is to try to let our patients live their life without always thinking about asthma, right? So we want you to go on vacation without having to worry about, oh no, if I have to go on a long hike, do I have my rescue inhaler? Like, will I have an asthma exacerbation? We try to keep our patients out of the emergency rooms, right? So nobody wants to go to the emergency room. Typically, it's a long wait, a lot of money. We want you to be able to use your PTO time for vacation and not because you're having an asthma exacerbation and you can't breathe. If you're breathing better, you are more productive at school and work, and life is just easier. So we really focus on aggressive treatment and prevention of asthma symptoms. Um, so really what our goal is, we give you medications like rescue inhaler, but we really hope that you don't have to use this 2 days per week or less. Typically, with our people who struggle with like exercise, we do have you use that prior to exercise. That really doesn't count because that's more of a preventative. But really, we're looking at people who feel good pretty much all day, every day. Asthma will typically get worse at night. So we usually ask about nighttime coughing, wheezing, shortness of breath, waking up with a cough. Asthma will typically come and get you at night. We also one of our big initiatives here is to avoid oral steroids. Oral steroids are wonderful for allergies and asthma, but overall, they can take a toll long term, especially with women. We're talking about decreased bone density. It can kind of shake up our own steroid making process or the feedback system that that our body uses. So we try not to use a lot of oral steroids. So one of the things that we see with new patients is, they get sick a couple of times a year and they go to the urgent care and they get like a course of oral steroids and prednisone. And our rule of thumb is that if you've been on 2 courses of oral steroids in the last year, that's generally a red flag for uncontrolled breathing symptoms. And so some people, for them, that's just normal, but that really shouldn't be something that's normal. One of the most common like triggers of an asthma exacerbation is a respiratory illness. It's ragweed season right now, so we are seeing people kind of feeling asthma symptoms kind of trickle, little things. So we're trying to be more aggressive with our daily control medication. But there are several different triggers of asthma, and sometimes all of these can affect a patient, and sometimes, it's very particular things. So in the environment, pollen, dust, mold, pet dander. When we talk about pet dander, really what we're talking about is the skin, the saliva, or the urine. So some people think how hairy something is how allergic, what kind of symptom it'll be more likely to cause symptoms, but that is not the case. Respiratory illnesses, just your average regular cold. The average person is going to be sick for, 7 to 10 days and they should get better. The cough should completely resolve. If you have a lingering cough after your average run-of-the-mill cold, like everybody in the house got the cold, everybody's better, but you're still coughing, that is usually a sign that you have a reactive airway disease. And so you have some like inflammation in there. We have some patients who only use inhalers when they get upper respiratory infections because it will turn into bronchitis and then pneumonia because of the chronic inflammation and swelling. We at our office we have like a rapid like PCR swab, so we know within 15 minutes if it's the RSV, if it's COVID, if it's a common cold virus. This really helps us. Obviously, the patient, it's helpful to know what they have, but us as clinicians, we like to know what we're up against. So if an asthmatic has RSV, they're more likely to be hospitalized because it affects their airways just so much more. It causes such a more of an inflammatory response. So that's a huge risk for us. Airway irritants, smoking, vaping, strong odors, perfumes. Like when you walk into the Hobby Lobby during the fall and you get those cinnamon pine cones, some of my asthmatics can't go to the Hobby Lobby during the fall season because of those cinnamon pine cones. So it's a little bit different for everybody. Cold air, hot and humid air. Sometimes even this time of year with the warm days and the cool nights, sometimes, that reactive airway does not enjoy those changes. Exercising. So exercise is tricky. We want our asthmatics to be able to exercise, but there are certain things we're going to go over in the next couple of slides that's going to help our asthmatics do it well and prevent exacerbations. But if you go from not exercising at all to heavy, vigorous activity, especially if there's environmental factors at play, that can definitely trigger an asthmatic response. So one of the questions we ask patients is if you get to laughing really hard, do you go into a coughing fit? That is like a little nuance of asthma. Stress, anxiety, or just strong emotions can trigger an asthmatic response. Certain medications, so like ibuprofen, some people have a sensitivity to this, and some blood pressure medications can actually make asthma worse. And then other things like workplace, like chemicals, fumes, that kind of thing, those are just basic airway irritants. So really what we try to say is, avoid the things that trigger your asthma as best as possible. But what we try to do is, again, try to give you good control so you can live your life. So most of our patients, we have what's called an asthma action plan. So we kind of go through what symptoms to look for, when to use your inhaler, when to call us. Um, so basically, the controller medication is their daily medications. This is meant to be used as like a prophylactic treatment. So we're trying to prevent asthma symptoms before they even begin. So even if our patients aren't having symptoms, we still want you to use this daily inhaler because that means that that is working and doing what it should be doing. The rescue inhaler, a lot of people, when they first come to our office, they've been living on the rescue inhaler. That is really not what it's meant for. It is a very short-lived medication. It only lasts about 4 to 6 hours, so it's not really meant to be used several times, throughout the day. That's a sign that usually we're not, our patients aren't well controlled. So consistency really with the daily inhaler is what we really try to tell our patients. Of course, avoiding triggers, things that worsen your asthma. Like if you have to clean out the dusty attic and dust is a huge trigger, you can wear masks, have somebody else, hire somebody else to do that. But sometimes, it's hard to avoid. But we try to work with our patients to give them tools to use if they do have breakthrough symptoms. But we have same day sick visits at our office, so you can come see us when you need us. And then for people who are their asthma is basically provoked by allergens, what we can do is allergy immunotherapy, which is basically desensitizing you to your allergens, and that helps reduce your asthmatic response. So, and then for people who are doing all the things they can, they're using their inhaler, but they're still having breakthrough symptoms, then we start talking about biologics or injectable asthma medications. These are a lot of people don't enjoy the idea of shots, but usually these biologics get to the root of the cause of the asthma. So whether it's allergic or eosinophilic driven, these medications are going to get to that root of the cause. Okay, so again, we have the rescue medications. This is just meant to use when you have breakthrough symptoms. This, again, does not treat the inflammation. And remember, the inflammation is that key driver for the mucus and the narrowing. So this kind of just quickly opens up the airways, but then within the next 4 hours, those airways are going to shrink back down. Controller medications, again, these are the first line of control. We want them taken every day. It helps reduce the inflammation, and it helps prevent flare-ups. Now, people often get scared when they hear the word steroid, right? So, oral steroids are systemically absorbed, right? So you take it in your mouth, you swallow it, it's metabolized, throughout your body. The inhaled corticosteroids, these are not systemically absorbed. We can prove this because if we do like lab work, we can tell that like the white blood cell line isn't affected by these inhaled corticosteroids. So just one pill of oral steroids is still is more steroid in your bloodstream than using the controller medication all year round. So we just like to make that distinction because a lot of people hear steroids and they get nervous. And then again, if the controller medications aren't working and we're still having a lot of breakthrough symptoms, then we talk about the injectable medications, which again, they're targeting specific inflammatory pathways, whether it's allergic, eosinophilic, or TSLP driven. And so these are kind of just, there's mild asthma, moderate asthma, severe asthma. Really, if you're using that rescue inhaler 2 or more times a week, we say we need to do better. This is an example, is kind of what like our asthma action plan looks like for our patients. We like our patients to kind of feel comfortable adjusting their medication, kind of having backup medications to start or use when they start feeling symptoms. Like today, I had a patient who was like in her yellow zone, so we added like nebulized budesonide to her daily inhaler to try to prevent her asthma symptoms from kind of worsening to help hopefully avoid the like oral steroids. So she is going to get that started and hopefully that'll keep things under control. Some of our patients you're going to see here like the peak flow. At our office, we have something called a Luna, where it's basically like a remote pulmonary function test. So we can kind of tell your lung function from afar. And we work with a respiratory therapist to make sure that those numbers are where they should be. So, and this kind of just helps the patients feel comfortable, using the medication when they kind of empowering them to be an active participant. One of the most common reasons for poor asthma control is actually using the inhaler incorrectly. So I have a lot of patients who say, you know what, I'm picking my medication up, I'm using it daily, and I just don't feel like it's making a difference. So there are some basic things that we'd like to go over. Sometimes it's as simple as just not shaking or priming the inhaler before you use it. So it depends on the type of inhaler, but like a meter dose inhaler, like the regular like puffer, if you will, we want you to give that a shake for 5 seconds before you take it. Sometimes just not having a good seal around the medication, around the inhaler, the medication kind of escapes from the sides. So we want to make sure that, we have a good seal. If kids, especially kids, will have trouble with this, there are devices like spacers that help the medication go into the spacer, and then the child can use kind of still get that medication from the tube. A lot of people need to don't know this, but you usually take a deep breath out before you use your inhaler. So you take a deep breath out and then you take a deep breath in. So that kind of makes it just easier to get that medication into your lungs. With the meter dose inhalers, there's a couple different kinds. This is like the standard puffer. Sometimes people kind of huff and puff and they like don't quite get the medication. So it's just easier to start kind of breathe, like press the inhaler and then breathe in slow and deep. Some people just hit it too hard and it doesn't really get to where it needs to go. Some people, when they get the medication in their lungs, they don't hold their breath for as long as they should. So they basically breathe the medication right back out. And then the big one for us, especially with the controller medication, is we want them to rinse their mouth after using the inhaler. Because there is steroid in most of these inhalers, we increases the risk of things like oral thrush or voice hoarseness or throat irritation. So we do want you to rinse and spit with just water. You don't need to use mouthwash or the super aggressive like Listerine that can actually increase the risk of thrush. So, sometimes by the time patients get to our office, they have voice hoarseness and they think that's just like a normal thing that they have to deal with when it comes to using an inhaler. And there's not, there's several different types of inhalers. The potencies are different. So definitely if they're struggling with anything like that, that is completely unnecessary. Every once in a while, we will re-educate our patients. We'll have them show us how they use their inhaler, just so we make sure that that they're using it properly. So yeah, that's a big one for us. We're trying to, allow our asthmatic patients to live their best life. So a lot of patients will say, okay, well, exercise makes me feel worse, and so I don't want to do that. Well, that really is not the best way to live life, right? So we know the benefits of exercise. And actually, when exercise is done well, it actually can, strengthen your lung function. So we basically try to, sometimes we'll have people use it prior to exertion, but really the most important part of exercising with asthma is actually warming up. We want you to kind of like ease into it if you can. 5 to 10 minutes, kind of just doing things like jumping jacks, just kind of get things moving, get everything warmed up. We monitor, obviously if things get too hard, we want you to stop. But generally, if you ease into it, you should be able to do all the exercise that you want to do. And then when you're done with the main event, we want you to cool down, just kind of catch your breath, make sure your heart rate comes down appropriately. Sometimes an abrupt stop can cause an asthmatic exacerbation. Obviously, you are going to call us if, our patients will call us if they do, like sometimes like marathons and stuff, they'll say, I just don't feel like I'm recovered well. We have some tests that help us assess like inflammation and pulmonary, the pulmonary function. So sometimes we'll do those tests if people aren't feeling like they are recovering well. But the biggest triggers during exercise is cold, dry air for sure. That cold winter air is definitely a big trigger for asthmatics. Pollution or poor like air quality, like the wildfire smoke, like that's been huge. Obviously, you don't have to be, you're not really allergic to the smoke. It's just an airway irritant. So asthmatics, avoidance is really the best policy for the wildfire smoke for sure. And then it says, I put eating large meals before exercise, and that's more or less because it can actually cause acid reflux, and acid reflux can really not play well with asthma. Sometimes you aspirate that gastric acid that can create that inflammatory response. So we want to make sure that we're not having reflux when we're trying to run and control our asthma. So this is the allergy and asthma connection. So a lot of people don't really understand the relationship or the fact that these asthma and allergies are related at all. So, but they definitely are, because when our body is exposed to an allergen, it provokes an immune response. So our immune system is basically overreacting to something that is not a threat, but our immune system doesn't understand that. So it releases like inflammatory cytokines or proteins, and that causes airway inflammation. It can cause nasal inflammation, throat inflammation, sinus inflammation, but it can definitely affect the airways as well. Um, when we do have that inflammation in the airways, that basically creates an additional hyper-responsiveness in our airways. So after that, anything smoke, cold air, dry air, that can definitely make it worse. 80% of people with asthma have a coexisting allergic condition. So what we try to focus on is treating your allergies aggressively and by proxy treating the asthma. So common allergic triggers, like I said, this is ragweed season. That's a big one. Grass is a big one. Dust mites, those are, in the fall time when we start turning the heat on. That those little fuzzies that you see in the sunshine, that is dust mite excrement, and that is actually what people are allergic to when we talk about being allergic to dust mites. So that is a huge trigger when we start kind of blowing that around. The pet dander, again, that's the skin flakes, the saliva, and the urine. Mold, that is sneaky, that's soil molds, household molds. Cockroaches, of course, thank goodness out here, this isn't too much of a problem for us, but, bigger cities may struggle with that. So basically, if we try to look at the relationship between allergies and asthma, and if we treat your allergies, that should help make your airways less responsive. And again, that allergy immunotherapy, the goal of that is to kind of desensitize you to your allergens. So sometimes for some patients, that's a 2-for-1 treatment. So these are some of my favorite common myths about asthma. A lot of people say, well, asthma's only in kids and they'll outgrow it. That's definitely not the case. It can come at any age, and we can grow into it, we can grow out of it. We hope that kids outgrow it, but that's not always the case. The biggest thing, I hear from my patients is, well, I don't have any symptoms, so I don't think I need to use the medication. That's a sign that the medication's probably working. So we definitely want to be aggressive with the preventative part of the asthma exacerbation. Another thing, a lot of people don't want to use inhalers because they think that they'll become addicted to them. There is really no addictive medications in these inhalers. Basically, it just helps with the inflammation. In fact, I don't know if anybody here has used a rescue inhaler, but it's not a great feeling. Sometimes it can make you a little shaky, a little dizzy. The albuterols can be a little bit stimulating, so it's nothing anybody really wants. Using the inhaler means your asthma is severe. That's actually not true. We want you to use that as a preventative. The other side to that is if you're using your rescue inhaler too often, that is actually a sign of poor control. So again, we want to make sure some patients will mix up like the daily and the rescue. So we try to give good education as to what the daily is and what the rescue is. I have a lot of patients, and I don't, this is something that we're seeing, this integrative medicine. They try natural things and herbal remedies, hoping to cure asthma. There is really no cure that we know of for asthma. We basically just try to do our best to control it and prevent it. That's not to say that maybe homeopathic like allergy treatment would not be helpful. So if it is helpful to you and your symptoms, that's wonderful. But we're doing our best to treat everything across the board. Again, asthma will trigger asthma, or sorry, exercise will trigger asthma. So people try to avoid it. That's just not the case. That means that we're not doing a good enough job controlling or preventing the asthma symptoms. Um, Again, this myth about the steroids, people get nervous when they hear steroids. That is not the case. Like I said, these are the most effective way to treat and control the asthma for long-term success. A lot of people will say, "Well, I got an X-ray and they said it was everything was clear, so I don't think I have asthma." Yeah, unfortunately, when we talk about inflammation, that's soft tissue, and you're not going to see a lot of that on chest X-ray. Sometimes, if you're bad enough, they'll see some like telltale signs of asthma, but you can have a totally negative chest X-ray and still be like in a full asthma exacerbation. Um, the we have this new one. This is my newest favorite. Vaping is safer than smoking. Vaping can definitely worsen the inflammation, aggravate the symptoms. Now there's this bronchiolitis obliterans or the AKA popcorn lung. It's rare, but we have seen a couple cases of this from vaping because of the chemicals that are in there. So that is not the case. I do hear this a lot. Like if I, because I wheeze, I definitely have asthma. That's actually not the case. You can have several other conditions that can cause wheezing. So, we don't want to just be, oh, I have wheezing, it's definitely asthma. So we do try to make sure that we're treating you for the right disease. And if you don't wheeze, then you don't have asthma. I have some patients who say, I've never had to use my rescue inhaler, but that does not mean that you don't have a reactive airway disease. So, the takeaway for us is asthma is definitely serious. People still die from asthma exacerbations. That's kind of why we're aggressive with the preventative side of it. Um, we try to, again, prevent, control by using prophylactic inhalers. We give you the tools to use that if you do have breakthrough symptoms, we hope that you can get those on board to try to prevent this from going further. We try to work with you. Like I said, we identify what allergens or what triggers you may have that might make your asthma worse, and try to address them if we can. Obviously, we want you to be able to resume, continue regular activity and exercise and that kind of thing. And that's kind of our goal as far as treating patients. Um, and if we always try to encourage patients, like if you talk to your provider about how you're feeling and they just say to, keep using your rescue inhaler, usually that's not a great way to control asthma. So we hope our patients actually don't have to use their rescue inhaler. So that's kind of what are the differences between being an asthma specialist and kind of just um, being, I guess, an asthma patient is we don't want you to have to feel like you can't breathe. So I took a long time, but does anybody have any questions?
Questions can be thrown in the chat, or you can just unmute and ask. I'm not seeing any questions in the chat.
Okay.
Um, I did find a lot of this information very educational. Things that I didn't know. I know my son has a few kids on his soccer team that have inhalers, so it's interesting to hear how, the pre-treatment versus, you've already run an entire soccer game and now you're looking for your inhaler, what the
Yeah.
difference is. Yeah.
Yeah, I
Um,
mean, it definitely, if we know that it's primarily, exercise driven, we will say just use it before. That really doesn't count as like the, 2 puffs per week or, 2 uses per week, because it's more of a preventative. But the trouble is if they use it as a preventative and they're still looking for that extra puff after the game, that's a big red flag that things could be better controlled for sure.
there is a question in the chat. Is it beneficial to make the gargle noise when rinsing to prevent the throat irritation with a control inhaler?
Um, I mean, that's, I guess I never really thought about that, but if it's a robust rinse and that's what you need to do to make that happen, definitely. We just want to make sure that none of that medicine is kind of lying around. So yeah, do a vigorous swish and spit it out.
Not seeing any other questions.
Okay.
I do appreciate your time today. This is very useful. We will follow up with the recording and the slide deck for all those who registered for today. And I really appreciate your time. Thank you so much.
Thanks so much for having me. You guys have a good day.
All right, you too.
Okay. All right. Bye.